Good evening, everyone. We welcome you all to OrthoTV original webinar series. Today we have two senior orthopedic surgeons. In fact, I should say two arthroplasty surgeons who are dealing with primary hip arthroplasty on a day-to-day basis and also revisions. But we are going to talk on implant choices in primary total hip arthroplasty. We have Dr. Girish Dewnany, who's a consultant arthroplasty surgeon in Hinduja Healthcare Hospital. And we have Dr. Atul Panghate, who's a professor in KEM Hospital and also a consultant in Criticare Hospital in Andheri, Mumbai. So this webinar is brought to us by GSK Consumer, the makers of Iodex Ultra Gel. So over to Dr. Girish Dewnany.
Okay, thank you, Neeraj, and thank you, OrthoTV, for giving us this chance to share our experiences. Our topic for the day is implant selection in primary total hip arthroplasty, and we'll try and simplify this as much as we can. Now, out there are a huge number of options available for somebody who needs a hip replacement. It could depend on what type of bearings are preferred and whether the fixation strategies involve cement, uncemented, hybrids, etc. Now, how to make a little more sense of the options available is what we are going to start with. Initially, we will discuss a few bearing options, including dual mobility systems and the use of constrained liners before we move on to fixation strategies. In this, I will be accompanied by my very good friend and colleague, Dr. Panghate, who has a huge experience with cemented hip systems, which he will be tackling. So without much ado, let's go on to our first topic, which is the bearing options in a total hip arthroplasty. Now, bearing surfaces in any hip replacement are critical. They are critical to the long-term survivorship. They're critical to good function as well. Our patients requiring hip replacement in India are definitely younger than what we see in the Western world. They have, as expected, higher expectations. They are more active and they would like to do some sort of a sport if possible. And the aim is to give them something which will last longer. It's not going to last them their lifetime if we do somebody at the age of 25, but at least for a good 20, 25 years if possible. The bearing to which all others should be compared would be the chromium cobalt on the ultra high molecular weight polyethylene, which is usually sterilized with 2.45 to 4 megarads in air, with a linear wear rate of about 0.01 to 0.02 millimeters per year. Now, this is a ball standard, and we try to see how the newer bearings compare to this. Now, this stock may have a little bit of tribological inputs, but we will try to keep it as minimum as possible. At the end, you will realize that it is more experience-based than evidence-based. So what is maximum survivorship based on? It's going to be something where there is reduction in the osteolysis, which is bound to develop wherever we use polyethylene. And that is a big indicator as to how long this particular joint will function. Secondly, optimized function is important as well, with increased stability and increased range of movement. Young patients have a 10-fold increase in lifetime demand. So doing a hip replacement in a 75-year-old sedentary at-home individual is very different from doing it in a 35-year-old very active young man. So what are the approaches that we can use to reduce the wear and the osteolysis? First of all is the material combinations, whether we use cross-linked polyethylene, whether we use ceramic on ceramic. And earlier, that was also the rationale for metal on metal, which of course now has been put on the back burner for various reasons. Component geometry, in fact, which refers to diameter of the head and clearance, is important, and we will touch on that in a minute. Performance parameters that we consider to reduce osteolysis is the volume of wear, the size and shape of the particles, and how biologically active the debris is. So range and arc of movements are two things which are a part of component design. Range of motion is what the patient can do, and arc of motion refers to what the implant can do. And the arc is determined by the implant design, by the femoral head size, and also by what is called the head is to neck ratio. Range of motion is always limited by impingement, which is something which any primary hip arthroplasty needs to avoid as much as possible. The arc of motion is proportional to the femoral head to neck ratio. A large head and a small neck will obviously give a larger arc of motion. And this is something which newer stems are incorporating more and more. The range of motion proportional, as we said, to head and neck ratio. There is some limitation by impingement, and a small head is at a greater risk of dislocation compared to a larger head. And this has to be kept in mind when selecting an implant. Impingement can, of course, predispose to dislocation, which is the one single problem that we would like to avoid in any primary hip or revision hip arthroplasty. Neck geometry also affects the arc of motion with a trapezoidal or oval neck, increasing the arc, which is compared to a circular neck. So implants, again, now have given preference to this, and most current implants, if you see, will have a trapezoidal or an oval neck compared to the circular ones. Now, this is a debated topic, whether we should use a large head or a small head. There are reasons, pro and cons in each. The large heads obviously are more stable. They give us an increased range of movement with decreased pressure on the articulation, while the smaller head has a less range of movement, but it has reduced friction, and it allows the use of a thicker polyethylene. The smaller head was a hallmark of the original Charnley arthroplasty, and the reasons for that will be clear in a minute. Today, we are more in favor of large head sizes, but the commonest range we use is 28 to 36. 36 and more is not really recommended unless you're using ceramic heads in certain specific situations, which we will discuss. So impingement within the range of movement will cause limitation of range, increase the wear, and also increase the risk of osteolysis. And while impingement can be minimized by maximizing the head to neck ratio, matching heads with the acetabular implants, better femoral stem alignment and acetabular alignment, and a trapezoidal neck. So this is what we have in control of us. A range of arc of motion will be on the implant, and the head and head neck ratio. Large head, as we discussed, this dislocation risk is reduced, and liner wear can sometimes be increased in large heads, and the neck shape is important. So this is what Charnley is our gold standard, a 22 millimeter head with a conventional polyethylene. This is where the graph stands in terms of survivorship and function. Our aim always being to optimize the function by increasing the head size, increasing the stability and the range of movement, and to maximize survivorship by reducing the wear and osteolysis. Now, when Charnley started doing his hips with the polyethylene that he had, it was he had the principle that as the head size increases, the lubrication, which was the boundary lubrication type, directly related to increased wear of the polyethylene. And that is how his philosophy of using a smaller head, or what he referred to as the low friction arthroplasty, came about. Now, our aim is to increase the head size, but if you do a conventional polyethylene with an increased head size, as shown in this graph, the higher wear is a deterrent factor, and we are not going to get any benefits as we set out to do first. So what happens with polyethylene? If you have a hard bearing on a polyethylene, there is particulate polyethylene debris, there's a activation of the macrophages, and there is subsequent osteolysis and aseptic loosening. Now, highly cross-linked polyethylene is what we now use, and that has definitely more benefits compared to what Charnley had available to him. The reduction in wear rates is about 70%. It is more brittle. It is sensitive to malalignment compared to the old polyethylene, and there is up to 4-fold reduction in osteolytic potential of the highly cross-linked polyethylene compared to the conventional polyethylene. Clinical studies have shown a 70% reduction. Sometimes the highly polyethylene particles are most reactive, but definitely smaller. There are concerns regarding increased wear when using highly cross polyethylene in active patients with larger heads. And this is more to do when we are using heads above the size of 32. So on a conventional scale, we don't tend to go beyond 36. but that is only if you're using ceramic heads. I will come to that in a minute. So this is where we have improved on the Charnley graph, as in we can use bigger heads now with a better quality polyethylene and still expect it to strive better than if we were using the same with the conventional polyethylene. So we've improved that aspect of it, of increasing head size and increasing stability. But can we do better? Yes, we can. Sometimes we can do better than using cross-linked polyethylene, and that is what brings us to what is called hard-on-hard bearings, wherein we have either initially been using metal on metal, and nowadays we have the option of ceramic on ceramic. Are these better solutions for younger and more active patients? Well, only time will tell. But in my personal experience, ceramic on ceramic has got a place in the younger individual, but ceramic on highly cross-linked polyethylene still remains the most used bearing throughout the world. I had a chance to do a lot of metal on metal heads, and I'm just sharing a couple of follow-ups to tell you that it is not a bad option at all. With 14-year follow-ups in this patient of a 40-year-old bilateral ABN with a large head metal on metal arthroplasty done, or these two young patients who were both between the age group of 30 to 40 with 12 and 13-year follow-ups. These are implants which have been now taken off the market because of levels of metal ions, suspected toxicity. This is all Western studies. There have been complication rates quite high in the Australian and other registries, and there have been a situation where the main implant which Depuy was marketing has been withdrawn. I personally have done over 25 such cases, but luckily have had no issues, and I think that is the experience of most of our Indian colleagues as well. It is a technically demanding procedure. As you see, the cups do not have an anchoring screw, and they are monoblock cups. And secondly, they are very sensitive to malalignment. So they have to be put really in the right position to avoid impingement and subsequent loosening, which has been seen in many studies. But that metal on metal now is just a topic only for discussion. What we are using now is more of something called ceramic on ceramic. The ceramics have revolutionized the bearing scenario in hip arthroplasty, where the alumina ceramic showing 50 times lower wear than the moderately cross-linked polyethylene. The ceramic on ceramic hips have got very low wear volume. They have very small nanometer size wear particles, and the osteolytic potential is 100-fold less than medium cross-linked polyethylene, moderately cross-linked, sorry. The ultra-high molecular polyethylene fares much better on this score. And the biological activity, again, is much less of these ceramic alumina particles. The biocompatibility is much higher. There's a much lower level of osteolytic cytokines compared to even ultra-high molecular polyethylene. And the best option is a 28 to 36 millimeter head size. There is a situation where a larger ceramic head has been used in what is called the delta motion type of hip, which we will discuss when we discuss the uncemented hip systems. You are able to use larger head sizes, but it is more so used for smaller cup sizes rather than going for a head which is 40, 44 or such. But there are certain problem areas. There are issues of squeaking, brittleness of the material lends it to being risking of fracture in cases of malalignment, and sometimes there is a chipping of the acetibular liner at insertion. So ceramic on ceramic certainly allowed us to move on the graph towards the lower wear scenario with improved function, reduced wear, and reduced biological activity of the particles. So ceramic on polyethylene is certainly what we are using now more and more, and all throughout the world. There is a significant decrease in the wear compared to metal on poly. Wear rates are about 0.75% of metal on poly. The disadvantage being that the taper tolerance is very sensitive and you cannot revise with an existing taper. There is always a small risk of a ceramic head fracture. So this is a classical example of a 40-year-old bilateral avascular necrosis patient who had both his hips revised using ceramic on highly cross-linked polyethylene. This is what is used throughout the world, and we will discuss it briefly when we move on to the unceramic systems. It is certainly my workhorse when I'm doing revision cases, whether it's revising a cemented hip to an uncemented, or even in complicated primary hip scenarios. So as I said earlier, all bearing surfaces are subject to impingement, but hard-on-hard bearings are much more sensitive to malalignment and impingement and their consequences than polyethylene bearing surfaces. So polyethylene, ceramic on ceramic is less forgiving than polyethylene, and therefore as a surgeon, you have to be more precise in handling these bearings. So what do I prefer? My decision is based on a few factors. First is, of course, life expectancy and the patient demands. Size and weight of patient. I will not be very comfortable using ceramic on ceramic in a very heavy patient. Cost is something which we only think about in the Indian scenario. The Western scenarios, Western world tends to have that, not have that problem rather. But in Indian scenarios, we have to be very sure, because the difference in cost between a metal head and a ceramic head, for example, is around 10 to 15,000 at the least. And an implant with satisfactory medium-term results. And as I said earlier, it is more experience-based than evidence-based. Here is a good time to introduce something called a trunnion, which you can see in this diagram. I'll try and get my arrow to see it. This is something which is now gaining importance. And the reason why I'm showing you this is that the trunnion is supposed to be creating problems in scenarios where you use a metal head more than 32 millimeters in size. It's always important to use a metal head only up to 32 mm if at all you're planning to go towards that side. The reason I'm saying this is there are cost issues, and if these are taken into account, then a metal head is definitely more economical for our country. Just a minute, I seem to have. Okay, let's move forward. Now, oxinium is something which you must have all heard of. It is a new high performance bearing. It is a bit more sort of resistant to wear compared to metal on polyethylene, and oxinium on cross-linked poly, especially marketed by Smith and Nephew, has a good success rate similar to ceramic on polyethylene. So this is a ceramic metal alloy. It doesn't have the risk of chipping and flaking of fractures which ceramic has. So it is marketed as a good alternative to metal on highly cross-linked poly articulation. Some examples here: revising a failed transcervical fracture to a ceramic on poly total hip arthroplasty, a ceramic on ceramic total hip arthroplasty in a 30-year-old patient with avascular necrosis. But as you see, the surgical positioning, alignment, etc., has to be spot on for this to have no problems. This is a 22-year-old young girl whom I did a ceramic on ceramic total hip arthroplasty following a failed DDH surgery. In this, again, because if you're using ceramic on ceramic, you have to be very careful about the impingement and the aversion, so that there is no chip or end loading and no risk of brittle fractures at that area. Current philosophy is based on scientific and registry data. Avoid metal heads more than 32 millimeters for the risk of tunnionosis. Ceramic on highly cross-linked poly is the most commonly bearing used worldwide. Oxinium is preferred in some centers, but it is only marketed by one company. Ceramic on ceramic in my practice is reserved for the younger patient, and a head size more than 36 millimeters is usually not desirable, as it increases the risk of trunnion wear, less so in ceramic heads, but definitely the risk increases if you go beyond 36 mm, even in ceramic heads. So that's where we move on to our next thing of what next bearing that has now come into vogue is the dual mobility cup, where the head articulates within a retentive poly liner, which is then free to move in a metal back shell. So this is something which is commonly used now, and you can procure this in a couple of companies which are selling this in India. The dual mobility systems have increased stability and which is more helpful in scenarios where the soft tissues are poor, in cases with neuromuscular problems, or in some complex situations where you're taking down an ankylosed hip in a young patient. Of course, it is very helpful in the revision scenario, but we will discuss that at another time. So this is how the range of movement improves in a dual mobility, but there is a risk of what we call intraprosthetic dislocation. Very less, but it has to be kept in mind that it can happen. Though overall, it has shown great promise in improving the stability and in patients where that is a moot question. The dual mobility cup is usually uncemented if you're using, but then there are options like this Evolutus, which has come out with a cemented dual mobility option, and it is definitely more cheaper. The heads can be either ceramic or metal depending on the patient affordability. The constraint liner to round off the stock are used in situations where there is very poor abductor function, insufficient soft tissues, and the implant position otherwise is okay, and the polyethylene liner in an uncemented socket is of the constraint variety. You have now started cemented constraint implants also now being available, and they are used as a final salvage in patients who are unstable or dislocating. You have to keep in mind that the longevity of these constraint liners is usually around 7 to 8 years. So it's not a great idea to do it in younger patients. It's better to do a formal revision and get the implants properly aligned. Sometimes we do this as a primary option, like I did this in this 93-year-old demented lady with an intracapsular neck femur, or in this patient who was, again, in her early 90s, who had a bipolar done with dislocated and had to salvage it with a constrained liner. But as I said, it remains a salvage option. So with this, I leave you from this part of our talk, and I hand you over to my colleague, Dr. Panghate, who's going to talk to us about cemented hip systems, and then I will come back and talk a little bit about the uncemented options available. So friends, bear in mind, bearings play an important role, and understanding which one you would prefer is important, and cost factors will dictate as to your cost. So if you're using metal on highly cross-linked poly, you're fine as long as you stick to a 32mm head as your maximum. While ceramic on ceramic has to be used with a little bit more care, implanting it in surgically, it's much less forgiving. Thank you. Atul, all back to you, please. I'll stop sharing my screen.
Atul, we cannot hear you. Hold on. Let me unmute you.
Is that okay?
Yes. I just start from the beginning.
Okay. So now I'm going to elaborate on cemented hips and how to get it right so that they last long and function well. Our journey into the field of arthroplasty started in 1960s when Dr. Sir John Chanley did his first cemented hip in Brightington, and from there we've really come along a long way, and we really now know exactly what to do and what not to do to a great extent. So cemented hip started in 1960s, still continues to be a quite commonly done arthroplasty world over. Long-term results are now really known world over. So, but of late, if you can see the younger surgeons, the number of cemented hip replacements are reducing, and there are a few reasons for it. The first and biggest reason is the fear of failure, which some of us have seen these kind of x-rays and fear that this is purely related to the cemented hip and have gone away from cemented, which is actually not true. Or so it's not that only the cemented hips fail, the uncemented hips fail too. So what is the reason for these failures? We've analyzed this, and now we can really conclude that the main reason was the polywear and the poor cemental. The polywear was related to the poor bearing surfaces, as Dr. Dewnany has already elaborated on what happens if you use poor poor quality poly, and it leads to poly wear, and which then leads to early loosening and failure. Another reason for avoiding cemented hips was the fear of intraoperative complications like the bone cement implantation syndrome. But again, I would say it is a lot more hyped rather than the truth. There is a chance, but again, we can minimize by taking a few steps intraoperatively. Another reason is because the surgeon doesn't have great confidence in his own cementing techniques and fears that doing an uncemented hip would be safer. Not really true. We need to really work on this cementing technique. So can you really avoid a cemented hip? For example, in a patient who is osteoporotic has a Dorsey type of canal. Here, because of osteoporosis and wide canal, your uncemented is not going to have great fixation, and you can really have problems with that. Or in a post-infective or post-traumatic scenario where the quality of bone and the amount of bone is going to be very, very problematic, and you may not get a good primary fixation, and cemented hip is only way here. Or shorter patients. Many of our patients are less than 5 feet 3 inches, and the cup required here is about 36 to 40 millimeters. Again, the uncemented system, most of them start from about 44 millimeters. And on the canal side, if the canal is less than 8 millimeters, you really are stuck because there are hardly any uncemented systems in that size, and you're forced to do a cemented. Again, as for us in India, the cost really matters, and for the same choice of bearing, a cemented or a hybrid hip is easily 40 to 50% cheaper than a cemented hip. Some of us may be forced to do a cemented hip purely to reduce the cost of the surgery, and hence have to adopt the cemented hip. Cemented hip is always kept as a standby for an uncemented hip in case you are not able to attain good primary stability. So if it's going to be a standby, we better know how to do it correctly. Again, revising a cemented hip is much easier than revising a well ingrown uncemented hip. So again, revision is easier with a cemented hip. So all the budding orthopedic surgeons really need to know how to do your cemented hip well. Otherwise, you may be stuck up with issues on tables. So now we can easily know that the causes of failure are purely because of polywear, which Dr. Dewnany has really told on the importance of bearing. Polywear leads to osteolysis and loosening, and the second reason is poor cement mantle. So you can conclude that to get a good result in cemented hip, one needs to select a good processes, select a good cement, plan your surgery well, take a few careful intraoperative steps to achieve good cement mantle, and you can be assured of good long-term results. If you go through a literature, which again, there's a huge amount of literature since we've been doing it for the last 60 years, we can easily conclude that the most important thing that leads to failure is the bearing. And as Dr. Dewnany has already told you, the highly crosslink on metal and highly crosslink on ceramic is today the gold standard in doing in a hip, and the wear rates are much lower than the conventional hips, conventional poly, and so this should be what we should be using. Again, when it comes to poly, remelted poly is always better because it has lesser free radicals and there is no oxidation. A compression molded poly during manufacturing is better than machined poly because it has lesser wear. Sterilization technique again is very important, as Dr. Dewnany has already told you. Ideal would be a ETO sterilized in vacuum. Again, you have to also look at how long the cup has been on the shelf. As the cup is lying on the shelf, there is oxidation of the poly, which leads to earlier wear. Again, the flange cups have done well because the flange cups restrict the escape of cement and enhances the cement penetration of the bone and leads to better fixation. This is a new feature that has come up. Nowadays, the cups have methyl polycrate with methyl polycrate spacers, which again help you attain a good cement mantle and prevents bottoming. So by using these kind of cups with these kind of spacers, we can achieve good uniform cement mantle rather than the bottoming out which we see once upon a time. So we can conclude that today, if you are going to do a cemented cup, then it has to be made up of highly cross-linked poly. It should be preferably remelted. The method of sterilization, you need to know what it is. It should not be lying on the shelf for a long time. Use a flange cup. Use a cup which has cement spacers or pegs, and pressurization also is important to get a good cement mantle. So in our market today, if you look at the available cups, these four cups which are there in the market are which are the ones which fulfill all the criteria: the rim fit cup by Stryker, the reflection cup by Smith and Nephew, the CHCA cup by Zimmer, and the marathon cup by Degu are some of the examples. I'm sure there are a lot more from by other companies, but whenever you select a cup, see to it that it has these kind of features, so that then you know that this is going to give you a good result long term. The next step is to get the technique right. The first step in achieving that good technique is to have a very good exposure of the acetabulum. We should be able to see the acetabulum all around 30 degree, 360 degrees view is very important. You need to see and identify the tal, the osteophytes need to be seen, and you also need to visualize the medial wall of the pelvis properly so that you can insert your cup and do a cementing very well. Again, a new set of retractors do go long way in achieving that. Here you can see the cup all around, all the 360 degrees of the cup is really can be seen nicely. You can visualize the tal properly, and then that is the first step. The next step in doing a good hip, a cemented or an uncemented hip, either of them, would be to ream properly. General mistake that everyone does is to ream less, and that you end up putting the cup which is far more lateral and inferior as compared to what you want to achieve. If you just keep on reaming in that same direction as you want to put your cup, like at 45 degrees inclination, you end up raising the center of the hip, and you end up putting the cup in at a much higher hip center rather than you need. So the ideal technique would be to first ream medially and then go superiorly in the inclination that you want to do. So this is the ideal technique, where you take a small reamer, first horizontally ream till you reach the medial wall or the floor of the fossa of the acetabulum. Then direct your reamer medially in the inclination that you want to do, so that you put your cup in the correct center of rotation. Here is an example where you can see I first put my reamer medially, reach the medial wall, and then put it in the correct inclination, so as to put the cup in the right position. Sometimes you end up you see a lot of osteophytes on the acetabulum, and this is an instrument which some of the systems give. It's called a rim cutter in the Stryker system, which helps you trim the osteophytes which are overhanging over the rim if you cannot place your cup properly. The next step would be to introduce the anchor holes. The anchor holes help us achieve a good penetration of the cement into the bone, and which helps us achieve good stability to the cup and good hold of the cup. Nowadays, it is recommended that you do multiple holes of about 5 millimeter depth in all the zones. Here, I usually use the flexible drill that comes with the uncemented system, so that you can really go into all the zones and make multiple holes. Generally, about 25 to 30 holes is what I generally end up with. You also make small anchor holes in the ischium and the pubis. Always remember, the anterior-inferior part or the anterior-inferior quadrant of the acetabulum needs to be avoided, because the wall there is thin and you may just go into the pelvis and damage some critical structures. This is another instrument which is now available in most of the sets. It's like a sucker which you insert at about 12 o'clock position. Here you can see me insert this iliac sucker on at the 12 o'clock position, and when you correct the suction to it, it sucks out all the blood in the cancellous bone, and then you can get a good dry bed of bone for cementing, and then there is no blood interposition between your cement mantle. Next step would be to graft the cyst. There's sometimes you end up seeing an acetabulum which has multiple cysts. There's always a gap behind the tal, which you need to fill up with some bone grafts that you have. Otherwise, what you end up with is an escape of the cement on the medial side, which can damage some critical structure, and also sometimes looks very ugly on X-rays. So always take some bone graft and pack it behind the tal, the way I have shown you here. The next step would be to give a nice pulsatile lavage. So take a nice pulsatile lavage, give a thorough lavage, remove all the soft tissue, bone, blood, marrow particles from the cancellous bone. After that, once you achieve this stable and dry bone bed of bone, then you can really again pack it with sterile hydrogen peroxide soak, so as to maintain this dry bed for you to cement well. The next step would be to select your cup, which is generally 4 millimeters smaller than the last reamer that you use, so as to get about 2 millimeters of cement mantle on all the sides. Take your cup, do a trial positioning of the cup. Again, mark the final position of the cup. you want to put it with some marker like methylene blue, so that after you cemented, you inserted your cement and put your cup, you can put your final cup in the position that you want to, and really don't compromise on the position. So this is what I normally do. If the flange is very big, I will trim the flange, put the cup, do a trial reduction of the placement of the cup, and mark that position with methylene blue before I start mixing my cement. The cup is then dried and washed and dried, and then I start mixing my cement. And the next step would be to pressurize this cement. Remember, all the cement pressurization should happen with the cement pressurizer, and the cup should not be used like a pressurizer. What the pressurizer helps us is to achieve is good penetration of the bone into the cement into the bone. Generally, the initially I has to use pressurizer which were handmade with glove and some gauze pieces, but nowadays we're using this newly available disposable pressurizers. Generally, the pressurizer selected is about 4 millimeters larger than the last rubber that you use, so that it can seal all around the acetabulum and prevent the cement with the pressurizer for about 4 to 5 minutes till the time it. By the time it usually is good enough for you to insert your cup. Remember, the amount, this time will all depend on what cement are you using and your OT temperature. Generally for Palacos or Simplex, which are normally used at about 1.5 minutes, it's correct to insert the cement into the acetabulum, and about 4 to 5 minutes of pressurization using the pressurizer is okay for me. After that, you slide off the pressurizer. Don't try and pull it off. If you pull it off sometimes because of the vacuum that is created, or if the cement is stuck to your pressurizer, then it might just come out with the pressurizer. So see to that you slide off your pressurizer and don't pull it away. After that, you remove the excess cement that you see all around, and then you insert your cup. Take the cup on your cup holder if it is of a smaller size, and then first introduce it horizontally and medially so that it rests on the towel, and then gradually incline it to the desired position, about 40-45 degrees of inclination and about 15-20 degrees of anteversion. By doing this, you prevent the escape of the cement inferiorly, and you get a very good cement mantle along with the all around the cup, and you will have a good cement mantle in all the 3 zones. After that, you remove your pressurizer, use the system as a pressurizer till the cement cures completely. You can remove the excess cement all around. See to that your cup is resting on the towel at this time, and also parallel to it, so that you know that the inclination of the position of the cup is perfect. After your cement cures completely, remove all the overhanging osteophytes or cementophytes if there are any, so as to prevent impingement and dislocation later on. So if you do all this well, you can end up with a cement, a cup which is nice cement. So if you go through literature, there are 2 designs which have done very well and have given us good results. The first is the composite beam kind of system, or the composite beam kind of stems, and the second is the taper slip kind of system. One by one, we'll see what it really means. So the composite beam stem is the one, or the shape closed design is the one which has roughened surfaces, which is sometimes pre-coated. Sometimes it has a collar as a rough finish, sometimes may have flanges and grooves. The few successful designs in all over the world are the Spectron by Smith and Nephew, and the Lubinus by Link. The main purpose or the main aim in this system is to form a very strong bond between the bone, cement, and the stem, so that all the stresses are then passed onto the implant directly onto the bone, The downside here is that it will be noticed that it usually shields the proximal femur, and you sometimes get some amount of demineralization of the proximal femoral bone. Also, because it needs a very strong bond between the stem and the cement and the bone. The cementing technique has to be very good, and generally it is not a very forgiving implant system if you have cementing technique is not good. So gradually this system is now becoming less and less popular and is used at very specific centers, but still it's giving good results in those centers. The more popular system which is available all over India is this taper slip type. Taper slip type, the stem is made up of a highly polished stem which is collarless and tapered. The designs which are available, or the stems which are available in India which are collarless and polished and tapered, are the Exeter stem by Stryker, the CPT by Zimmer, and the C stem by Depew, as well as the CPCS stem which is by Smith and Nephew, and there are lots, some more also. There are few Indian manufacturers, but whenever you select a stem, see to that it is collarless, polished, and tapered in today's scenario, because that is what is going to give us good results and help us get good outcome. So basically what happens in the taper slip stem, gradually the stem subsides by a few millimeters initially, which leads to radial compressive forces which are transferred onto the proximal bone, and which prevents, passes the strain on the normal stresses onto the bone and prevents the stress shielding of the bone. The most important part of this stem is the centralizer, which usually has a small air-filled gap there for the stem to subside and subsequently become stable gradually. So as the stem subsides by a few millimeters over the first year or so, basically there are hoof stresses which are generated in the proximal femur, which are passed on to the proximal femur, and which leads to which prevents stress shielding of the bone. Here again, perfect cementing technique is really not needed, and it is forgiving. So even a junior consultant or a junior resident can start doing this, and generally will have good results. Now the material of the stem is very important. Today there are so many local manufacturers. See to it that the stem is made up of nitrogenized stainless steel or chromium cobalt. This is a system which I use very frequently. This is the Exeter system, which comes with multiple offsets and multiple stem sizes and head diameters which are possible. It also allows me to select multiple bearing options, right from metal on highly crossing poly to ceramic on highly crossing poly. And if I go to a hybrid option, I can even use a ceramic on ceramic tip, which is today pretty important. The Exeter system offers you multiple offset options for the same canal size. Also, you can also use insert the stem correctly so as to accurately reconstruct the femoral geometry, and you can end up with a perfectly reconstructed offset as well as horizontal and vertical offset, and you can reconstruct the proximal femoral geometry accurately and give a satisfactory outcome to your patient. Again, the newer femoral retractors help you gain good exposure. Here you can see the femur, you can see correctly. This is the medial side, this is the trochanter that you can see. Once your exposure is, once you expose the femoral well, the next point would be to make a good neck cut. Generally, all the systems come with their own marker or their own stencil, so as it allows you to take the proper neck cut. Generally, about 1.5 to 2 centimeters of neck is kept from the lesser trochanter. Exact osteotomy is not important if you're using a collarless stem, because you can adjust your stem depending on where you want to keep it so as to reconstruct your proximal femoral geometry. Again, the entry into the canal is very important. You need to make an entry which is about bit posterior and bit lateral, so that you end up in the center of the canal in the lateral view. If you make your entry a bit central, what you end up doing is you tend to come and touch the posterior wall, or if you do not incline it properly, you may touch the anterior wall. Again, when the stem touches the anterior or the posterior wall, you can have a deficient cement mantle there, and sometimes the patient can even complain of thigh pain, especially in an uncemented hip. So take your box cutter, make a good box at the posterior and the lateral side of your bone, and gradually keep on broaching with your broaches. Again, you don't need to ream. Nowadays we broach the femur so as to preserve as much bone as possible. At the end of your broaching, you should be able to see some amount of cancellous bone anteriorly and medially. That would guarantee you that you've broached in the correct direction. So when you are in the center of the canal and not touching any of the cortices. If you really have any doubt here, then you can easily take an X-ray intraoperatively, so that your your stem is right in the center of the canal and not touching either of the cortices. Then you broach till your templated sign and then see what kind of offset helps you to restore your, what kind of offset selection in the stem helps you to restore your offset to the exactly as to where you want to achieve as compared to the opposite side. Again, note the relation of the mark on the broach to the bony landmark here. You can see there are marks on the broach here, and which you have to see what is the kind of relation it has with the neck cut here or the tip of the trochanter here, so as to reconstruct your offset properly. Again, these marks will also be there on the final stem, and you can easily insert the stem till the desired position that you want to achieve as in relation to these bony landmarks. After that, you use a cement restrictor. This was first described by Robleski. You should aim to just have about 3 to 4 millimeters of cement mantle displayed to the tip of the stem, so that the system allows you to subside by about 1 or 2 millimeters that you want to achieve, so that you can get good amount of you can use the principle properly. Here is this exciter exciter system, where you can measure the size of the canal, and you can have this inverted cone kind of a restrictor, which helps you attain a good cement mantle. All companies have their own cement restrictors. See to that you use a newer cement restrictor made up of methyl methacrylate, and do not use this old Hardinge type of restrictor. Ask your your manufacturer to provide you this newer cement restrictors, which are very important and integral part of the cemented hip system. After that, once you've put your cement restrictor, give a nice thorough wash with your pulse lavage, so as to remove all the dead debris, the bone particles, the blood, etc. Then vent your canal and pack it with hydrogen peroxide, sterile hydrogen peroxide, so that you maintain this dry bed of bone which you have prepared. Always use a vent, because if you do not use a vent, then you can end up having some amount of embolism from either the trapped air or the oxygen that comes out from your hydrogen peroxide. Again, whenever possible, I try to use the vacuum mixing system, which is available easily with most of the manufacturers now, so that there are no pores or voids or air bubbles which are trapped into the cement mantle. You get a nice uniform cement mantle. Then use the cement gun with a proximal femoral seal and your vent, so as to start retrograde filling of the cement. Fill the cement till the tip. Again, then you remove your vent and pressurize the cement further, so as to get nice. When you pressurize it well, on the surface of the bone, you will see some amount of fat escape out from the bone, which is a sign that you are pressurizing it quite well. After this, I generally tend to pressurize the zone 1 and zone 7 with my thumb and a little finger, so as to get good cement penetration there. Because if you just use the cement, use the femoral seal, sometimes in zone 1 and zone 7 you might not see good amount of cement. So go ahead and then digitally pressurize the zone 1 and zone 7 there, so as to get good cement penetration there. Then select your stem from your trial, and then use your surgeon's thumb on the medial side as a pressurizer, which also prevents the cement leak, as well as it helps you to put your cement in your stem in good amount of valgus rather than varus. Once your cement is in, see to it that you have inserted the stem till the desired mark, which corresponds with the mark on the broach that you have which you have done in your trial. Again, prevent the medial cement escape and maintain the sustained pressure till the cement cures fully. After that, again, you use your trial head. See to it that your offsets are properly reconstructed. Measure them with your scale, and again reduce your hip, and see to it that you attain the exact limb length correction that you need to achieve from your pre-op planning. So if you do all this well, you can end up with a hip which looks beautiful, as well as which functions very well. I would like to thank you for your patience here. Now over to Girish for your uncemented hips. Yeah, Girish, I've stopped sharing the screen now. Girish, you need to unmute, I think.
Right. Can you hear me now?
Yeah, we
Atul?
can hear you. Well.
Yeah.
Yeah, fine. Go ahead.
Yeah. Thank you, Atul. That was a very exhaustive expose on how to do a cemented hip. And as you very rightly said, the cementation part is certainly the most important deciding factor after we've taken into account the improved bearings. And it be well for every surgeon who's doing cemented hips, whether as a part of the hip replacement or as a bipolar arthroplasty, to pay very stringent attention to how a stem is cemented. And if you're doing a cemented socket, then how well you should prepare and then cement the socket. In all these situations, a use of a pulse lavage is mandatory and recommended, and good quality polyethylene use is also important. So let's move on to the second part of the talk on uncemented hip systems. These are certainly gaining in popularity. And first, we move on to the acetabulum. Now, an interesting situation which I would like to share is in 2000, when I attended the American Academy of Orthopaedic Surgeon meeting in the US, about 98% of all arthroplasty surgeons were using an uncemented acetabulum. And at that stage, I was in training and working in the UK, where about 50% of surgeons were using uncemented and 50% were using cemented. And the usual refrain in the US, in the UK was that the Americans don't know how to cement, and that is why they're using an uncemented system, which I think was very clearly brought out by Atul's talk, which specified how important the technique is to get a good result. So when we talk about uncemented acetabulums, we have systems which can take a metal cup with an insert which could either be metal, which was used in the metal on metal scenarios, polyethylene or ceramics. Uh, Design concept, I must admit that I personally use the Pinnacle system by Dewnany a lot, and it has given excellent results with good long-term registry data. So a few of the concepts that the Dewnany Pinnacle shell involves will be elucidated here. It's a dome which was 140 degrees of the interior of the shell, and a big, large dome loading area for polyethylene inserts. It has a self-locking taper mechanism. It can increase the variability as to what type of liners you can use with this. And it has got some anti-rotational devices to have secure holding of the liner to improve stability and have less wear. Now, all these uncemented sockets are lined by materials which improve integration into bone. They have to, if you understand, do the role of the cement, and they depend on primary stability. If you are not going to depend on your screw fixations for stability, then you're going to have a cup which fails very soon. And Porocoat is the most common material used, which allows the bone to bond to the implant. There should be no intervening fibrous tissue, and it also prevents ingress of debris, thereby the osteolytic potential which can be expected when you're using a polyethylene liner is reduced to a very large extent, though not eliminated. So at 4 weeks and at 12 weeks, if you see the histological picture, there is progressive ingrowth of the bone into the implant, allowing it to get a secure bond, which is definitely long lasting. Now, what Atul didn't mention was that in the series of Charnley, which has had the best results, the only weak link actually was the cemented acetabulum in younger patients, and hence the need to devise a mechanism to improve the longevity of this acetabulum, and hence the preference for the uncemented socket. So this is commonly used and has been considered as the one that shows the best ingrowth with a rigid initial fixation. Now the Pinnacle cup and some other cups also come with a lot of options to give what is called an enhanced stability to the liners. You can have a neutral or a 10-degree liner with +4 options. There can be constrained liners, and sometimes you can even use the same thing with a dual mobility option, which you will see later. So it's a neutral +4 or a 10-degree +4 liner that is used for the pinnacle socket. The pinnacle range has got options of using what is called a bantam cup, which is used in some small acetabuli, as you see in DDH scenarios. You can have a multi-hole pinnacle cup used in situations where there's protrusio and you want more enhanced fixation, or a sector or a cluster hole where you have 3 holes for enhanced screw augmentation. The product range is pretty diverse, and it is something which you should be aware of whenever you're choosing an implant system. Now, I must stress here that whenever I use an uncemented system, whether I'm using the Zimmer with its trilogy system or the Depuy with its pinnacle system, I always have a cemented cup as a standby. Now, when I say standby, it is in scenarios where I might find the bone to be not very good in quality, porotic, not giving me a good initial fit, then I may shift over to a cemented system, or in situations where I find that the posterior wall or the supporting wall of the acetabulum would not take a socket of the size which we want, then a cemented option. But it is not very frequent at all, but it should not be something which you should dispense with. Now, Zimmer has its own trilogy system with options of a multi-hold or a cluster-hold shell, and again it has the same range of liners. Now, I'm not going to go into the details of insertion of this socket, but suffice to say that most of the steps elucidated by Atul in terms of how to get a proper exposure are mandatory in putting a uncemented socket. The TAL has to be identified, anterior posterior walls to be delineated. One thing that I must say is the rate limiting factor in insertion of an uncemented socket is the integrity of the anterior and posterior wall. So while you're preparing your socket, initially deepening it and then widening it, you have to keep palpating the walls to make sure that you're not wearing them out too much and not getting a posterior wall blowout, which is a complete unmitigated disaster on table, which even a cemented socket will not be able to salvage, and you will be forced to come back a second day and put in a cage construct to get over that problem. So the uncemented sockets are more unforgiving, if I can say, compared to a cemented socket. They give you one good bite at the cherry, and if you don't justify the socket use, then you will be left scratching your head, and you may have to bail out to a cemented situation. So please prepare your socket properly. First deepen, then widen, using the TAL as a reference, and get the best hold possible. You can augment with the screws. The screws need to be, in your mind, an optional feature. Your primary cup should be so stable that you may even feel that you don't need the screws. So screws sometimes become a situation key. If they are there, we can use them. But if you're going to depend on them for stability, then you're going to be in deep trouble. So this is a Zimmer system, which is equally user-friendly, and I've personally used it many times. Now, all these cups are suitable for high-performance bearings to give you an optimized function and a higher range of movements. They are good for large diameter heads, but as I said, 36 should be our last size if we are using ceramic, and 32 if we are using metal. Exceptionally low wear rates if you use these high performance bearings. Biolox Delta is the commonest ceramic in use now. Whether you want to use it as a ceramic liner for an acetabular socket is a choice of the surgeon. And ceramic heads certainly are far more versatile and preferred compared today to metal heads, even if you're using a cemented polyethylene socket as Atul showed. The pinnacle cup is can take both types of liners, either initially the alumina and now the Biolex Delta. There are two sockets available with the Depuy range. One is the pinnacle, which is a hemispherical socket, or the Duralock, which is the older version but a much more shallower socket. But now, personally, I would prefer the pinnacle because the coating is better and gives you better initial fixation with subsequent better ingrowth. However, the cost factor can be a deterrent because the difference in the cost of a Duralock and a pinnacle is close to rupees 20,000, which is quite a bit in our scenario. Delta motion was something which I alluded to in my talk on bearings. This is a monoblock system, ceramic system, which can take either large or small diameter heads. My personal view is that we should stick to a 36 head, even using a delta motion compose system, but it is very useful because you can get a 36 head with the delta motion cup of a smaller diameter. So if you use a 46 or a 48 cup as the picture here shows, you can get a 36 head in, which is not possible otherwise in a conventional system where you have a ceramic liner inserted. There, to get a 36 head, the minimum cup size that you will require would be a 52. And in our Indian scenarios with small ladies and small bone stocks, that may not be a possibility. So if you want to use a 36 head, but cannot get more than a 46 or a 48 cup in, then your delta motion is your best option. It gives you high stability with low wear and does not cause the problems that we had initially faced with inserting an acetabular liner. It tends to chip and sometimes crack. Here it is a single construct, so there's no liner required, and it has got a combined metal and ceramic wall of about 5 millimeters. So this shows how it gives you an increased range of movement when you have a bigger head and more stability with a higher jump distance. It is a little tricky in usage, as there is no optional screws to support it. In case you're getting an 80% hold, you cannot really use this system. So when you're using an uncemented delta motion system, you not only need to have a cemented backup, you also need to have an uncemented backup where you can anchor it with screws. So the inventory really goes big. The principle remains the same. Preparation is that much more critical, and the insertion is a little more technically demanding because you need to have a proper grip and initial stability. This is one lady who was about 58 or so with bilateral hip AVNs, small sockets which I opted to use a delta motion and get a 36 head in place. Now, we do have acetabular cups with special coatings for bones which are not very, very good, and also sometimes in the revision scenarios. The first of them is the Gription cup, which is similar to the pinnacle socket, but with a special coating which is for enhanced bone ingrowth in areas where the quality of the parent bone is not very good. There are augments available of the same material to bridge bone gaps of acetabular bone defects, which were initially used to be filled up by either cement or bone graft, but here we are using augments to give it a more stable fixation primarily. The Zimmer has a better range in what we call the trabecular metal or the tantalum cups, again extremely expensive but extremely effective in the desired scenario. Both these systems, Gription and tantalum, work with the whole range of liners, whether they are durability, that is still yet to come in India but launched abroad. They have hooded or 10-degree lip liners, and they also have constrained liners. Durability we spoke about in the bearing scenario, a little more focus here to show the amount of range that can be achieved with this type of system. And as we said, it is used in scenarios where the problem is with the soft tissues, neuromuscular weakness, or where we expect instability because of conversion of ankylosed hips, or certainly in situations where we are converting failed proximal hip fractures to an arthroplasty scenario where the soft tissue is compromised to start with, and we do not want to risk instability. Revisions, of course, it's an important adjunct. This is the intraprosthetic dislocation I was alluding to. It tends to be seen sometimes when there is a wear of the retentive polyethylene liner and can cause problems which has to be then revised. Here we can see that the range is improved with the dual mobility liner as compared to a conventional liner as seen in figure C. The striker is the currently most commonly marketed dual mobility system in India. It has a cup which is the same cup which we use for a conventional uncemented total hip. It has got screw options to augment it with a metal liner and then a poly insert over a femoral head. So this is my personal choice when I'm using a dual mobility system. The only setback in the striker system is if you're going to use a striker stem, which we'll come to in a minute, we don't have any long stems. So as you see in this picture, we've used a cemented exitus stem. It's also showing you this what we refer to as an intraprosthetic dislocation, where the polyethylene liner, which is the covering the femoral head, has got worn away. The Evolutus is another system available in India. It has an uncemented cup which does not have supplementary screw fixation. It has just got the fins as the X-ray shows there. The advantage of Evolutus is it has got a cemented dual mobility option, which is a great help when you're talking about conserving cost or doing it in poor quality bone. It has again got ceramic or metal head options along with the retentive polyethylene liner. We also need to just mention about constrained liners, which are best used with uncemented hip sockets. These are basically in situations where the abductors are very weak or neuromuscular issues where high dislocation rates are expected, or also in situations where a patient has a well-fixed uncemented socket, but for some reason is got multiple dislocations, so the polyethylene liner is changed to a constrained liner. As Atul would also agree, we do have cemented constrained implants now available, again for the same reason where the quality of inherent bone is not good. The Zimmer system also has its own constrained liner. The earlier system I showed you was a depot system. So on the same patient which I mentioned who had a bipolar hemiarthroplasty and at 5 weeks dislocated and then was revised to a constrained liner because she was not somebody who had good quality soft tissues, and I wouldn't trust her to follow instructions if I just did a conventional hip replacement. A primary constrained liner in a demented fracture neck femur I discussed earlier, or another exited bipolar which was then salvaged with a constrained hip liner. So a constrained hip liner is a good option to have at the back of your mind, but it is not going to work if you have implant malpositioning. So that is something to be kept in mind, that this liner is only going to be a worthwhile option if your implants are well fixed and well positioned. Using it as a primary scenario in scenarios is gaining prominence in very old patients who are having cognitive issues. Okay, now we move on to the uncemented femoral stems. Now, who is the person who gets these stems? Now, the commonest femoral stems are the ones which are coated either with hydroxyapatite or porous coating. They rely on bone in growth or on growth, and they maximize transfer of stress to bone. They are basically recommended in young active patients with good bone stock. They do aid in preservation of bone stock and have now got data, registry and otherwise of more than 20 years of follow-up. They occupy optimum metaphyseal space and they have a shape which resists axial rotation. This is a similar picture that we said, whether they are hydroxyapatite or porous coated, or could be a combination of the coating. They are designed to encourage bone on and in growth, and at 12 weeks, histological pictures show very successful ingrowth into the parent bone. The types of material we use are either a cobalt chromium or a titanium stem. Titanium is now getting more preferred, but its disadvantage is it is not sensitive and there is a slightly increased risk of fracture. The cobalt chrome disadvantages are more stress shielding and resorption of proximal bone. The type of stem that we are using should either have a macro lock, which is related to the implant shape, and a micro lock, which is related to the surface finish. Ingrowth and outgrowth, on-growth, sorry, are both integral to the longevity of the uncemented stem. So the design rationale for any uncemented stem is initial mechanical fixation, followed by biological integration or optimal load-bearing transfer and leading to maximal survivorship. Now, there are a whole variety of uncemented stems available in the market today, and cemented stems, though, have a fantastic track record. The preference is more going towards uncemented, one underlying factor being to try and avoid the cement implantation syndrome, which I agree with Atul, doesn't have much basis, but that is where the world is tending to go. So the first type is a single wedge stem. Then we have the double wedge. Third variety is the tapered stem, cylindrical stems, modular stems, and even the last being the anatomical stems. The short stems have been around, but personally have not had, and I have not had a chance to use them, and I'm not very comfortable. So I tend to use type B, which is the double wedge, the type C, which is a tapered, the cylindrical, the modular, and sometimes and also the single wedge. So A, B, C, D, and E are the five types of uncemented stems that are in use a lot in our practice. This is a type 1, which is the proximally coated single wedge stem, which engages in the metaphysis. It has a 3-point fixation, and you have to be very careful that in certain femurs, it should not just have a distal fix with no proximal support. That is where it tends to be a problem. The accolade, the taper lock, accolade striker, or the ML taper by Zimmer are classic examples of this. Type 2 stems are the double wedge stems with proximal cortical contact in both AP and mediolateral planes. These can be used quite well in the door type A femurs. They do involve broaching and reaming, and the Summit by Dupuy, an excellent stem, is also an example. The Synergy by Smith and Nephew also fits the same criteria. Type 3, the tapered stems, and personally, and in India, we have the type 3B, which is the classical Wagner. It's a titanium tapered stem. It comes in two options, either the Wagner cone, which is a shorter stem, or the Wagner revision stem. The only disadvantage of the Wagner revision stem is that it is a straight stem. So after 200 mm, if you want something longer, a longer stem, then you are risking a perforation because the femoral bow is not accommodated, and it's then possible to use the stem after 200 mm only with some sort of a femoral osteotomy. The Wagner cone stem I will come to in a minute. It is a shorter version and gives you good options. The type 4, the extensively coated stem, was the AML, and now it is the solution stem. The solution stem is more or less used in revision scenarios or in certain complex scenarios where we need a distal fixing stem of a longer variety. They are not good in door C canals, as Atul alluded to, because the quality of cortical bone is extremely poor there and they don't have much hold. They depend on a scratch fit and technically, again, very demanding if used. The modular stem or the SROM, they have separate diaphyseal and metaphyseal components. It is used predominantly in scenarios where there is metaphysio-diaphyseal mismatch, especially in scenarios like the DDH, where there is altered rotational malalignment or a previous femoral osteotomy. It depends on good proximal bone to get purchase of the metaphyseal sleeve. The anatomical stems are not available in India, but they are different sided stems, right or left, but personally, I don't have much experience of using them. So we just skip over that. Okay, the stem which is most often used in the Indian scenario is the Depuit Korai stem, which is a hydroxyapatite coated stem. Okay, so the reason why HA coating is helpful, it helps to decrease the migration of the components, and there is excellent bone ingrowth at about 12 weeks. There are contentions whether porous coating is equally good, but HA being bad is not yet proven, so it is still used as a first choice. The Korai is definitely the most successful uncemented stem on the market, going by registry data and clinical data. It has got 22 years of unchanged clinical heritage, comes in a variety of options with the collared, not collared. It has got a high offset option variety available. It has got a revision option available, and it also has a cemented option available. So it satisfies my requirement of always having a cemented backup when I'm doing an uncemented system. The preparation not being any different. It can take all high performance bearings. The Korai has vertical and horizontal grooves, provide initial rotational and axial stability, and a tapered stem. It's a tapered stem both distally and proximally, and does not cause much soft tissue damage because of lack of a lateral shoulder. The aim is to change your mindset from a fit and fill uncemented stem to a more compaction scenario. Compaction broaching has an advantage, does not remove too much bone. There is more physiological weight distribution, and compared to cementing, as we mentioned earlier, cement implantation syndrome is not much of a risk. So this is one of the studies showing excellent response to the Korai stems with 97.6 satisfactory fixation at a mean of 15 to 20 years. These are some of my cases, young and old, where I've used both the cemented and the uncemented options of the Korai. The X-ray on the X-ray, the bottom right shows a cemented version of the Korai used. The reason I used it in this patient was this was conversion of a girdle stone to a total hip, and the cemented option allowed me to sink my stem further compared to an uncemented option. I've used this with my metal on metal heads, the large ASR metal heads, which have gone into disrepute. But as I said earlier, we've had no issues, and if they are put technically correctly. The summit stem I use occasionally. There's a different philosophy to it. It's a proximally coated stem, and again accepts high performance bearings. The rationale for surgeons choosing a proximal porocoat is that the load transfer takes place in the metaphysio-diaphyseal junction. The diaphyseal bone is preserved for future revisions. That basically means that if we do a proximally coated stem in a young patient, if it comes down to revision, then revision is that much easier compared to, say, a fully coated stem, which might involve a femoral osteotomy to remove that stem. So that is one of the reasons why in younger patients, a proximally coated stem might be a preferred surgeon's choice. The Summit has also got 2 offsets per size, and it increases the offset without affecting the leg lengths. Full offset range covers about 95% of the population, and it has got some very good sort of studies to show its effectiveness. So it's got all features which addresses whether there is a proximal distal mismatch, immediate rotational stability, preserves distal bone for future revisions, long-term fixation and survivorship with excellent range of movement and functionality. The Zimmer range has the ML taper prosthesis, which is a proximally coated single wedge taper stem. Again, excellent track record. I have personally used it with great results, and is recommended by anyone who feels that the proximal coating is a preference. I personally tend to use it for the younger patients who might require a revision in the future in about 15-20 years time. So this is the features of the ML tapered stem. Again, when you're using this, keep the CPT system or any other cemented system as a standby, and it has got all features that give a good response with good initial stability and a 12-14 neck taper. Now, coming to the next group of stems is the S-ROM. Now, this stem, as you can see, the X-ray shows a dysplastic hip with significant femoral shortening. I've had to do a femoral osteotomy here, a subtrochanteric shortening osteotomy, and then used a S-ROM stem here where the proximal bone is prepared independent of the distal bone. You can see here I've used a 22mm head. That is because the socket in these patients is very small and can only take a bantam 38 or 40 acetabular cup, which can only take a 22mm head. So this is the S-ROM, versatile for metaphyseal diaphragm mismatch. Essential proximal bone stock is important. Version adjustment is possible irrespective of proximal sleeve position. This is again an important scenario in patients with childhood pathologies where there is a malformed femur, excessively anteverted femur, etc. This is a subtrochanteric shortening of another patient in a Crow type 4 DDH using the S-ROM stem. This lady I showed earlier, the ceramic on ceramic example, we had to use the S-ROM, and she had an excessive femoral anteversion of 55 degrees odd, but with the S-ROM, we could retrovert the stem within the sleeve by about 30 degrees and get a stable conjoined combined anteversion. Sometimes you may require to use revision stems in the primary hip scenario. So it's better to have some working knowledge as to what we have out there. First of all is a distal fixing chromium cobalt stem referred to, which is called a solution stem. It comes in 200, 225 or 250 mm sizes, 225 and 250 mm being bowed as per side to accommodate the femoral bow. 8, 9 and 10 inch lengths, 15 degrees anteversion, which is left or right. And the diameter of the stem is 1.5 mm more than the implant trial that you use. So you have to be very careful because this is quite notorious to cause hidden cracks in the bone, and therefore reaming line to line of 0.5 mm more is recommended. Examples where I've used the solution stem in a primary total hip is in cases where I've converted failed proximal femoral fractures, where you require a long stem to bypass the screw holes and get a good distal fit in the diaphyseal shaft. Another case where we use a solution system. In all cases where we have these screw holes, cementation is a little bit dodgy because we don't get adequate pressurization. And as Atul mentioned, if you do not get a good cement mantle, then the stem longevity is compromised. We have one more revision stem called the reef, which is an interlocking implant. It is used in cases where we require interlocking screws distally. As in this patient who had a failed subtrochanteric fracture, 85-year-old gentleman had a requirement of an implant which could give us the distal screw fixation while we allowed the proximal femur to heal. The Wagner is again a very, very popular and I must admit one of my favorite stems as well, available in both own prosthesis option or also as a revision stem, which is 195 mm onwards. If metaphyseal problems exist, then the cone variety of the Wagner is helpful. It, like the S-ROM, allows us to change the anteversion quite conveniently. If we are using a stem which requires us more than 220, then a femoral osteotomy is important as this Wagner stem is not bowed. These are a couple of examples where we've used a Wagner as a primary stem in complex trochanteric fractures in very old patients to start immediate mobilization. A failed subtrochanteric fracture here and a Wagner stem was used, but this Wagner stem luckily was a 195 millimeters, so we could get away without using an osteotomy and got a good implant. We've used it as a bipolar here because the acetabular side was not involved. Now, in some scenarios, especially where cost is an issue, a hybrid total hip is well documented and has got excellent results. So here is where we combine Atul's philosophy with the uncemented philosophy. We have uncemented acetabular socket and a cemented femoral stem. Remember, all points that Atul mentioned of preparing the femur or a cemented stem have to be taken on board and is used mainly where DOR type 3 femur with cost issues, poor bone quality are the main indicators. This is an example where there was a patient with from the interior with poor socioeconomic background had to give a total hip where we chose an uncemented socket with a cemented exeter stem. Another recent case where we used a hybrid total hip, this was where we were forced to do so because of tight soft tissues in the girdle stone or in a DOR type 3 femur where the socket, where the stem was just not suitable for any distal fixing system. So in conclusion, registry and clinical data support the use of uncemented hip systems in most patients, except in those with poor quality bone. Cemented standby options should always be available when using an uncemented prosthesis. Use of ceramic on ceramic is not possible in cemented sockets. That is probably the only drawback that I could see in a cemented system. But personally, I would prefer to avoid a cemented acetabulum with all due respect to Atul. And I would give my patients an uncemented socket with a cemented stem if at all I have any issues with costing. One more thing that I would want to add on is that in the Indian scenario, if you're using an Indian domestic local made implant, I am not very comfortable with the quality of the uncemented systems because the integration into bone is the single most important point. And what quality of coating these stems have is something I'm not very sure. So if I am pushed to use a cost-cutting system, then I may resort to an uncemented socket from, say, Depurism or whatever, and use an Indian cemented stem because there the cement is taking over much of the workload, hoping that the stem doesn't break into two at some stage, but that's the discussion for some other time. So long-term results with uncemented systems are now closely mimicking those with the Charnley cemented systems. And I think judicious decision-making is important as to which implant you would like to use in which option. Thank you very much.
Yes. Thank you, both of you. It was a complete comprehensive coverage. It will be especially useful for the people who are young arthroplasty surgeons who want to get into hip arthroplasty and want to know everything within 1.5 hours. So I think you have covered everything related to total hip. I have few queries personally because I don't do regular arthroplasties. So Atul, when would you do a uncemented hip? This cannot be cemented. So when will you do an uncemented hip?
A younger patient with good quality bone and he wants or deserves a ceramic on ceramic bearing. As Dr. Girish told me, explained that probably bearing ceramic on ceramic bearing or lack of option of ceramic on ceramic bearing is a major drawback in cemented. So a younger patient who wants a ceramic bearing, I would do an uncemented.
And what about you? When would you do a cemented hip, Dr. Girish?
Yeah, I would do a cemented hip in two scenarios. A, in a situation where I have very poor bone stock on the femoral side, or if I have a femur which is very capacious, will not give me an uncemented stem. As far as a cemented acetabulum is concerned, I would do it only and only if cost is an issue. On the acetabular side, I will do an uncemented socket, and I will really, really push to do a cemented socket because of poor bone. But otherwise, in 95% of patients, an uncemented socket is my first choice. On the stem size, I am much more lenient, can do a cemented stem. Cost, quality of bone, DOR type 3, all that would be my options.
So this question, any one of you can take. So ceramic on ceramic, they always say, many papers have also reported about the squeaking. Somehow I am yet to see a patient who is actually squeaking. So have you done or seen squeaking in ceramic on ceramic bearings, or do you do it so frequently or not so frequently?
Well, let's put it this way. The literature reported squeaking in a couple of specific implants, more of this old striker models, which have now been taken off the market. But now the current range that we have, whether the Zimmer or the Depuy, the squeaking issues are not so much. The second thing to say is squeaking sometimes may be completely distant with the patient but doesn't have any functional issues. So either you have to tell them to ignore it, or if there's implant malpositioning, it will have to be readdressed. But malalignment is the most commonest cause of squeaking today. The original papers reported squeaking after implants which have since then been withdrawn from the market.
What about you? Do you have this similar way or something else you want to say?
No, I agree with Girish. You hardly seen any squeaking in India. And again, it was with the striker system that some people had in the US. You hardly reported that in India at all, because that system was not really popular in India anyway. And again, if you really put your cup vertical, sometimes you may end up having edge loading, and that may lead to squeaking. But very rarely has anyone seen. As long as your orientation of the cup is perfect, I don't think the squeaking should be an issue.
So once when Ranawat had come to Mumbai, I think both of you are also there. At that time, he was too much on metal on poly, and he's not so much towards ceramic on ceramic. Now, though he's retired, but at that time, around 5 to 6 years back, he was saying that metal on poly works as good as ceramic on poly or ceramic on ceramic. So what is your take on it? Does it have longevity?
The take is very simple, Neeraj. Metal or hard bearings, which is ceramic on ceramic, are technically more demanding, have a higher chance of issues. However, compared to that, if you use ceramic on highly cross-linked poly, the change in wear is marginally higher. Mark my words, marginally higher than ceramic on ceramic, but gives you an infinite more chance of a better result in terms of technicality. It gives you a better option of using liners which are either 10 degrees lipped or +4, so that you can adjust for if you have any sort of instability in any direction, which is not possible in a ceramic on ceramic. So except for the very young patient, and if you're absolutely clear in your technicalities, I would go ceramic on ceramic. But highly cross-linked poly on ceramic is today the world's most commonly used bearing across all continents. Metal on poly, yes. If you have cost issues, yes, but not more than a 32mm head at any cost because of trunnion erosions.
Okay. And Dr. Atul, so one query for you. In the cemented stem, so is there a choice of cement which you use for the acetabulum separate and for the stem separate?
Generally, if you go through registry data, then if you see the Palacos is the gold standard today. Most of us have switched to Palacos, the medium viscosity cement that is available in the market, has very good results. So whenever you select a cement, again, go through registry data. There is huge amount of data on that, and which cement is failing and which is not failing is already documented. So today, I am using Palacos across most of the systems. Even if the manufacturer has some other cement, I would prefer to use Palacos and demand it on table. How about you, Girish?
Yeah, Atul, I want to ask you this actually. They tend to say that you should use a low viscosity variant of the cement on the femur side, while a regular viscosity on the acetabular side. Are you a proponent of that theory, or you think you could use you could use both? Like, I personally use the Palacos on the femurs on the acetabular side if I have to use. I use it on the femur side as well, but the Exeter results have all been with Simplex, which is a low viscosity cement.
Yes.
So Palacos has a low viscosity option. What is your take? When do you do the difference, or do you use both sides?
Whenever Palacos is there, I use both the side the same. But when it comes to Simplex, sometimes using Simplex on the acetabular side is sometimes very difficult. You have to use again a syringe or something like that. So on the acetabular side, if you are really able to handle the low viscosity, it is okay. Otherwise, best is to use a medium viscosity on the acetabular side and a low viscosity on the femoral side. So again,
Do you use Palacos low viscosity? I think they're marketing that now.
yeah, they started marketing, but again, the cost is a big issue with that. So
Okay.
again,
Okay.
I generally use Simplex.
Simplex. Second question: your view on antibiotics in cement in the primary hip scenario. Do you use plain cement or do you use antibiotics in cement?
Most of the time I use plain cement. Only if it is a post-traumatic hip or a previously operated, I would use a antibiotic cement. And again, when you're using an antibiotic cement, I prefer to use a commercially prepared antibiotic cement
Oh
rather than
yes.
mixing it on table.
No. I'm talking about commercial because you have a Palacos R plus G or
Yes,
you have a Palacos R, which
yeah.
is without the gentamicin. So that is still a controversy which many people tend to sit on the fence and are not able to comment on that.
I would not use a antibiotic cement in a standard primary revision because you just don't want to use the antibiotic. In case, for example, if you have an infection, something, what antibiotic are you going to use? You're going to use later on. So best would be to use a simple cement when you're doing a straightforward primary, and maybe post-traumatic situations or something like that. You may use antibiotics.
Okay. So thank you very much. We thank Dr. Atul Panghate and Dr. Girish Dewnany to take their time out and spare their time to this comprehensive coverage of total hip replacement implant choices. We also thank GSK Consumer, the makers of Iodex Ultragel, to bring us this webinar. Thank you very much and good night.
Good night.
Thank you.